lid reconstruction. The choice of procedure depend on the extent of lid defect. If it is small, less than 1/3, then this is a rough classification. If it is small, less than 1/3, we can do a direct closure with or without lateral cantholisis. If it is moderate, 1/3 to half, then a tensile flap, that is a semicircular flap, is preferred. If it is large, more than half is involved, the non-amblyogenic eye, if it is a non-amblyogenic eye, sliding tarsoconjunctival flap, that is Hughes procedure, is done. In amblyogenic eye, free tarsoconjunctival graft, that of the opposite eye, is taken. For total defect, mustard cheek rotation flap is preferred. In middle canthus defect, a glabellar flap is done. Now size of defect, it is like it can be classed, it should be assessed as given like this. For young patients, if the defect is 25 to 35%, then it is small. 35 to 45% medium, and more than 55% large. This is for young patient. In older patient, that is lax lid, the lid will be lax. In young patient, the lid will be tight. In older patient, if it is 35 to 45%, the defect is 35 to 45%, then it is small. 45 to 55% medium, and greater than 65% then large. For small defect, we can do direct closure. For small defects, direct closure with or without cantholisis can be done. Direct closure, usually a full thickness vertical pentagon shaped defect with point near the conjunctival fornix is created so as to minimize tarsal buckling and eyelid notching. Pentagon shaped defect. Then a 6-0 Weichel suture with atraumatic spatula needle is used for suturing. These vertical mattress sutures pass through the gray line, posterior lid margin and anterior lid margin. Here the initial bite of the suture is placed at gray line about 3 mm from the cut end. Here 3 mm from the cut end. This is the deep bite. Then the needle is emerged at 3 mm from the cut end on the other side at an equal depth. A return bite 1.5 mm from the cut end is taken finally to emerge 1.5 mm cut end on the side of suturing where it was started initially. On tying the sutures, a slight eversion of the lid margin after repair must be achieved so as to prevent wound contracture once edema subsides. The ends of the gray line and posterior lid margin suture should be left long so that they can be included in the knot of the anterior lid margin suture to prevent accidental corneal rub. The tarsal plate is closed with partial thickness bites using Weichel suture, and finally skin is sutured with silk 6-0 silk. Next, coming to tensile semicircular flap. Here it is used for both upper lid and lower lid defect. Here rotation of a semicircular flap, mucocutaneous flap, 18 mm horizontally and 22 mm vertically, beginning at the lateral canthus, extending upward for lower eyelid defect and downward for upper eyelid defect. For upper eyelid defect can be done. Cantholisis of the corresponding crease of canthal tendon is performed. A semicircular mucocutaneous flap, semicircular mucocutaneous flap plus cantholisis is done. Then direct closure followed by direct closure. Fixate the lateral canthus. Conjunctival advancement is done and excise extra skin. That is tensile semicircular flap. Next is Hughes procedure, that is tarsoconjunctival bridge flap. It is used for lower eyelid defect more than 50% of the horizontal length of the eyelid. The tarsoconjunctival bridge flap from upper eyelid is used for the posterior lamella. It is covered by a full thickness skin graft. Then later on it is covered by a full thickness skin graft. This flap is left in place for 4 to 6 weeks prior to the second stage separation. It is not suitable for one-eyed and amblyogenic eye. In Hughes procedure, we evert the upper eyelid here. Evert upper eyelid plus traction suture is given. Then tarsoconjunctival flap formation for upper lid. Then advancement of flap to lower lid defect. Full thickness followed by full thickness skin graft and flap separated after 4 to 5 weeks. Next, coming to Cutler beard procedure. Cutler beard procedure, it is used for large upper eyelid defect. A full thickness segment of lower lid tissue is passed. A full thickness segment of tissue is passed and under an intact bridge of lower eyelid margin and is sutured into the upper eyelid. Here full thickness segment of lower eyelid tissue is passed under an intact bridge of lower eyelid margin and is sutured into the defect of the upper eyelid. In the second stage, which is done after 6 to 8 weeks later, the flap is divided. It is not suitable for one-eyed and amblyogenic eye. Not suitable. Both this Hughes procedure and Cutler beard is not suitable for one-eyed or amblyogenic eye. Next, coming to median forehead flap. It is used for massive tissue loss in upper lid. And there is massive tissue loss in upper lid. Median forehead flap is used. The base of the flap is separated at 3 weeks. The disadvantage is that are a thick donor skin which is less mobile. Next is mustard rotational cheek flap. In this, it is used for vertically deep lower lid defects. The demerits are excessively long scar line on the face will be seen, and here a large superiorly based flap with medial edge at the nasolabial fold is outlined. A semicircular flap beginning at the lateral canthus and extending to the area immediately adjacent to the auricular tragus is dissected. With the superior limit of the semicircle at or above the level of the brow to prevent sagging of the lateral lid margin. The medial triangle is excised. And the posterior lamellar graft is placed and the rotational cheek flap is mobilized nasally. Next, that is about mustard rotational cheek flap. Next, coming to medial canthal reconstruction. Here the most important aspect of medial canthal reconstruction is the attachment of the edge of the lid prominence to the posterior reflection of the medial canthal tendon to restore the direction of the medial canthal angle. Medial canthal reconstruction, it can be either laissez-faire procedure, that is excised medial canthal area is left to heal by granulation, especially when periosteum is intact and the excision takes an equal amount or more above rather than below the medial canthal ligament, or a full thickness post auricular graft can be sutured in place, or a globular forehead flap can be used. The graft for anterior lamellar, we can take the skin from the same eye, opposite eye, retroauricular, supraclavicular or inner arm. For posterior lamellar, tarsal plate, heart plate, buccal mucosa, ear cartilage and pericardium. That's about medial canthal reconstruction.